conference will now be recorded.
We'll do our disclaimers now. AnCan is grateful to the following sponsors for making the recordings possible: Bayer, Foundation Medicine, Janssen, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics, and Boykin certainly for helping us record these sessions and making them available to the rest of us. AnCan notes that it does not accept sponsored promotions. Any drug protocols, devices recommended in our discussions are based solely on peer experience and clinical evidence. Please consult your medical provider for personal medical advice and discuss anything you hear here with that person as well. So Jeff W., let's go ahead and see what you have. What kind of questions you have today?
Yeah, this is my first time to this meeting. I went to the active surveillance meeting last week, and the feedback seemed to be, yes, you're in the right group, but I'm currently on active surveillance, but technically I'm in favorable intermediate based on the results from my most current biopsy, which was in August of 2024. My biggest concern right now is that my PSA is 8.5, was 8.5 on March 25th. I have BPH. I've been to 3 urologists. Well, let me back up a little bit. I was diagnosed in July of 2021, was on active surveillance. No concerns. I had no concerns until the biopsy of August of 2024, when my lesion went from Gleason 3+3 to 3+4. So the urologist I had then, said you can get radiation, or you can get a surgery, or you can just remain on active surveillance, which really didn't tell me very much. So I made
Let me go back and ask you some questions so we can pinpoint it, since it's the first time in this group. Jeff, you're how old?
68.
And where do you live?
15 miles south of Austin, Texas.
Okay. And when you had your biopsies, were they MRI fusion biopsies?
Oh, that's a good
or
question.
random biopsies?
I want to say, I don't believe they were random. I mean, they followed an MRI. They were dictated by the MRI that I had.
And they had a lesion that they were going after. Okay. So most likely that. Do you know the percent for in the cores that were 3+4?
Yes, 10%.
Okay. And how many cores were taken and how many were positive?
2 out of 12 were positive.
Okay. Did you have a second opinion on the pathology from either Dr. Zhao or from Dr. Epstein?
No, I didn't. But on recommendation from last week at the active surveillance meeting, I did contact Dr. Epstein, and he sent me the forms to send my slides off to them. And so I'm in the process of getting that together.
I think that would be relevant. What's the name of your doc in Austin that you're seeing?
My primary care physician, well, the urologist is probably more relevant. Eric Giesler, Giesler.
And what are your thoughts so far, and what questions do you have for the group at this point?
Well, my biggest concern is, number one, I feel a lot of urgency because my PSA was 7.3 on November 20th of last year, and then it went to my most recent result was 8.5 on March 25th. So given my PSA history, that's kind of a big jump. And what concerns me the most is that I've been told that if your PSA goes above 10, that puts you in the unfavorable risk category, which then could warrant hormone therapy, which I'm afraid of. I'm afraid of hormone therapy, frankly. So I really feel the urgency that I need to handle it. I made an appointment at MD Anderson back on November 20. I went to MD Anderson on November 20th, talked to a surgeon there, and he also said, oh, you can have surgery, or I can put you in touch with a radiation guy. Oh, there's another guy that does cryo, or you can stay on active surveillance. So there really wasn't any guidance. So I just went back to, learning on my own. And I thought, okay, active surveillance, okay, it looks like I've got some time. But now, when the PSA went to 8.5, yeah, that really upped the urgency quite a bit. And the BPH, when I talked to the urologist, the third urologist in my history here last week, he said, well, if you go to MD Anderson, they're going to tell you TURP, get a TURP. That takes 3 months to heal, so you wouldn't be able to get radiation for 3 months, which really makes me nervous. Or you could get aquablation, 4 to 6 weeks to heal. And I guess there are other therapies as well, but he says your prostate's too big for Urolift. They put it down as 57, almost 58 cc's on my biopsy. That was what the MRI of July 2024 showed. Anyways, getting to my question. My biggest concern: has anyone had to treat their BPH before they had radiation? Now, the urologist of last week, Eric Giesler, he originally said, I've had 2 meetings with him, one of 3 weeks ago and one of last week. 3 weeks ago, he said, you're a good candidate for focal. That was before he saw my MRI images. So he saw my MRI images, and then last week he said, well, you're not such a great candidate for focal because ultrasound, which both HIFU, which he specializes in, and Tulsa Pro, which I thought, boy, that looks pretty good, the best option. They both use ultrasound, and he said, given the size of your prostate, I'm confident that you have calcifications in your prostate, which the ultrasound will bounce off of. They won't be able to, they will block the ultrasound. So if you went full, the right side of my prostate, when I first had my first biopsy in July of 2021, found 1 millimeter spot of cancer on the right side, but it would never turned up again. It never turned up in two subsequent MRIs, nor in the subsequent second biopsy.
Okay, so there's a lot of things you gave us here that I think we can comment on. First of all, where you are now wouldn't force you to, one, feel urgency, or shouldn't force you to feel any urgency, and two, to rush off in treatment. You would still be a candidate, from what you've said, for active surveillance. Now, one of the problems with the NCCN guidelines is that they draw a fence, and you're either on one side of the fence or on the other. And so if you were 9.8, that would be less than 10, and you would decide that this is still favorable intermediate, and you wouldn't choose to do ADT. On the other hand, you're saying at 10.2, you would go ahead and say, well, I'm on the wrong side of the fence, so I'm going to do ADT, but I don't want to do that. I don't think that it's absolute in terms of how the body works. I think that the higher the number is, the more concerning it is, but I'm more concerned about a rate of doubling or a significant increase, which you haven't shown. You also have low volume disease. I think they'd have to look on the ultrasound to actually say whether there's enough calcium in there to prevent a HIFU or TULSA-PRO. I'm not a big fan of TULSA-PRO. I think if you're a good candidate for TULSA-PRO, you're a good candidate for active surveillance. But not everybody has a horrible time with ADT. And I think the very first thing you have to do is get that reading on the pathology and wait and talk to Dr. Epstein. And then you may also want to send off the pathology for Artera AI. And what that's going to do is pinpoint the risk of staying on active surveillance. And it will also tell you if you were to go through radiation treatment at this point, what would be the benefit? It'll quantitate whether the ADT is going to be helpful or not. And then you make your decision. If it turns out without ADT, you have a 90% chance of recurrence, but with ADT, it's down to 40%, then you might think differently than if it was a 41% chance without ADT and 40% chance with. You're not going to put up with the ADT for doing that. So I think the two things: one, hear from Dr. Epstein, hear from Artera AI, and don't stress about it. You're in a really good position, and the longer you can avoid things, the better off you are. I think that focal treatment kicks the can down the road. So as focal treatments may help with the BPH, and it may delay doing treatment, but if your treatment is bad enough or disease is bad enough that sometimes it comes to treatment, it will come to treatment whether you do focal or not. So it's expensive, it's wearing a catheter, it's risk of infection, it's anesthesia. That may not be necessary. Let's open it up to the floor to see if there are other questions for Jeff. Anybody? Nick, go ahead.
Jeff, have you, in regard to your PSAs, not that this would change your relative position and how you're thinking, but have you considered, let's call it somewhat of a strict diet, a non-inflammatory diet?
Oh, yeah. I have.
Okay.
I've worked on that
Okay.
quite a bit.
So if you've already been doing that, then that wouldn't assist your PSA.
Yeah, that's what I've been leaning on, you know.
So one question for you so I can get out of your way. You were talking about 10% before. I think you were referring to 10% of the core samples.
10% of the cancer found in my lesion was grade group 3, grade group 3, pattern 4. So
Gotcha.
Cancer is pattern 4.
My reason for asking for you to maybe check out is that Stuart and myself, for example, we were in a clinical trial in New York. Both of us had what they considered less than 5% pattern 4 of the volume of our prostate, but that was less than 5% of the overall volume, and that's why I was asking you that question. So if you don't know the answer, you could find that out. It's okay if you don't know the answer. I just was asking because that might be relevant for you.
Okay, Bill Franklin, you're up next. Bill, go ahead.
Yeah, I was talking the whole time, Mark, and I was muted.
Oh no.
No, I'm good. So yeah, Jeff, I just wanted to tell you, I don't have a camera, but I wanted to tell you that as far as your sense of urgency, I think there's several individuals in this group I can look at and tell you that we've all been there, right? We had a diagnosis, we had that sense of urgency, and it felt like we had to do something right away. Some of us had a much we're probably in a much worse situation than you were. Some of us were similar, but I'll give you two examples. My brother had BPH, had a TURP, got it treated. They said they detected prostate. They tested They test the tissue when they do a TURP, right? So they said they detected prostate cancer. And he went on active surveillance, been on active surveillance for several years. Never had a PSA over 7. I have another friend who's had a PSA up to 10, and it's been BPH the whole time. They've never detected prostate cancer, but his PSA has been elevated because BPH will elevate your prostate cancer. I mean your PSA, right? And they've never detected prostate cancer in him, but he's had prostate cancer problems for probably the last 10, 15 years that I've known him. So we're all a little bit different, but you will see similarities in a lot of people. But the one thing I can tell you is I don't think, from what I heard, and as Mark said, I wouldn't rush into anything if I were you. I think you're not looking at a knife edge here, right? So take your time, learn as much as you can, and go forward with what is best for you, because ultimately it's going to be your decision, right?
Yeah. Anyone else had treatment for
Joe,
BPH? Sorry.
yeah. Oh, let's go through the people who have their hands up, and then we'll come back. Joe and Victoria.
Oh, I just wanted to weigh in that I have a kind of similar circumstance with BPH and a 3+4 grade group 2 prostate cancer, and I'm just trying to understand I'm perfectly comfortable, and I've had how many biopsies? I had 3 biopsies and 3 opinions on my second biopsy. And they said the percent pattern 4 was anywhere from 0 to 20% on my samples, on samples. So you're going to get, with second opinions on the pathology, you might have a completely different worldview. So I wouldn't get too excited. I had I had Dr. Epstein say 5. I had the local pathologist say 20%. And then there was there was a secondary sample where Epstein said 0 and another person said 20% pattern 4. So this stuff is not in stone. The guidelines are guidelines, and I would relax about it and not rush into anything. That's just my advice. I'm not a doctor of medicine by any means, but I would hold back. And also, if for BPH treatments, I've been looking into it, and I find this HOLUP is a good one that's less that you because they use lasers, it cauterizes. There isn't much blood loss or swelling, and although it's somewhat radical in the sense that they remove the inside of your prostate, it's kind of low in side effects and kind of fast and much faster than a TURP in recovery time. So if that was a consideration, I've been looking into that, and I have tentatively an appointment in the fall in this winter to do it. So I'm still thinking about it. And I have 100 cc prostate, much bigger than yours. And the third thing is for focal therapy, I found this what they call IRE as an attractive alternative because it supposedly doesn't use the heat of a ultrasound and apparently less damaging. And they're all kind of a little experimental, but it's also called nanoknife or
Oh yeah, yep. Oh, nanoknife. Yeah,
they don't do it everywhere, but it's kind of a thing. Like if you go on the internet or if you go on these urological sites, a lot of people are raving about it. I don't know, it's probably too early to tell how good it is, and certainly I can't recommend it. I haven't done it, but I know one person who has, and he's very pleased with it. But that's just one person, it's just.
Well, Stuart's up next, and Stuart, you had this, and Nick also, you went through that, so you might both share your experience. You need to unmute.
So are you done? I don't want to cut you off.
Joe.
Oh yeah, I think I'm done. I just had those 2 recommendations, but yeah, thanks.
Hi, Jeff. I'll come back and talk about IRE in a sec. I just was curious. After your biopsies, did you have a DECIPHER or other tests done on
Yeah, I didn't get DECIPHER before I knew the difference between them or anything about them. My first urologist had me do oncotype, and the GPS score there was 20. Um, so that falls on the left side of the curve. Let's see, I can actually pull that up. It's not a good time. Had I known then what I know now, I would have said, no, give me the DECIPHER test. Because I hear that seems to be more prevalent and more standard. Patient's GPS result is 20. Likelihood of adverse pathology at radical prostatectomy, 31%. Adverse outcome, likelihood of adverse outcome, high-grade disease, 16%, non-organ confined disease, 18%. I guess that's chance of metastasis.
Yeah. Yeah. Technically, I think if you wanted, you could still go back and have them send a sample to get a DECIPHER. But that sounds like it's low enough that would fall on the side of not feeling like you had to rush. If that was really high, that could make a difference and could make the doctors have a different opinion on how urgent treatment was. Yours sounds like it's low enough, so I wouldn't overly sweat that. Did you have any of the genetic testing done to check for mutations?
No, I haven't. Now that would be different than DECIPHER, yeah?
Yeah, this is your inherited genetics mutations.
Yeah, no, I haven't had that.
Is the promise still open?
Yeah, it is. There's a website, prostatecancerpromise.org, and they will do a free test. We've got to move on here because we've got a couple of other people. Jay, if you have a comment.
Yeah, I'll try to be brief. Just listening in on the BPH stuff. 6 years ago, I had a procedure done called Resume.
Oh, yeah.
And it worked well for me. But now I'm at a different stage where they did a biopsy recently. And according to where they sent it, which was Emeritus, the result was 3+4 and 7, grade 2. And then Derek recommended, getting that. And you guys also recommended getting a second opinion. So they did send it out to Johns Hopkins. And they're saying there's not enough evidence to say that it is cancer, that it's likely mimickers. So I'm just waiting to follow up with my doctor on June 4th, UCLA doctor, Dr. Seigel. He's a urologic oncologist who I'm seeing now. And he sent it out for DECIPHER, and I did get the PROMISE test back, and they said there was no evidence of genetic mutation. That was it.
Okay. That's great. Let's move on to our next person here.
Thank you.
And if we have time in the end, we can come back and revisit some of the issues that we've had. Cesar, you say this is your first time in this group. How old are you now?
56.
And where do you live?
In Truckee, California.
Okay. And when were you first diagnosed?
Early 2021. I was first diagnosed.
And when you had a biopsy, was it an MRI fusion biopsy?
Well, I've had 4 biopsies of various types.
And what did the latest one show most recently?
The last biopsy, oh gosh, let's see. What was that one? Oh, gosh, the timing of everything is, there's so many dates now. I think it was last October. Last October, November. I think it might have been Halloween, actually. I had a saturation biopsy. It was a 30 core biopsy. And that gave me a Gleason 7, 3+4 was the.
Okay. And
I said that I don't think I've attended this meeting. I don't think I have, but some of you guys look familiar. So maybe it's just because I know I've been to the active surveillance group and the veterans group. And
how many on the 4? Do you know what % 4 there was?
It looks like 3 cores. I don't know the percentage.
Okay. So one of the things that would be helpful is to have that reviewed, as we've talked about, with either Dr. Zhao or Dr. Epstein. We're not big fans of the saturation biopsy. It sticks a lot of needles in, but it doesn't necessarily go after a target. And it turns out that a lot of people don't show lesions on their prostate on MRI, and just blindly.
I'm beyond that now.
Okay.
I had a radical prostatectomy on Thursday. So yeah.
How are you doing?
I'm doing okay. I'm not as I can't run any marathons or jump on a trampoline right now, but I guess I'm faring well for having a catheter and all the other stuff that goes along with it.
Do you have any questions for the group?
No. I just wanted to kind of I meant to join this group a while ago when I had kind of moved up to the low and intermediate category of having a PSA of 41 and a Gleason 7. Unfortunately, this is kind of the first meeting I could make, which is kind of after the fact. And I thought I'd join because I don't know if this group is really, has guys who have actually had prostatectomies or recently or any of that type of thing. So I thought
I don't know that we've had people who recently have gone through prostatectomy, but we certainly have had people here who can share with you their experience with prostatectomy, who've already done it, or just raise their hand and we can give a list on that.
Yeah, we do have people who have recently gone through. We've had a couple of people within the last three to 6 months, and it just depends on the timing. But just looking at this screen right now, there's at least half a dozen people in there who have done prostatectomies.
Okay. So it's not just guys that are active surveillance or
there's no active surveillance in here. This group is only for people who are either considering a treatment choice or who have just made a treatment choice.
Okay.
And in fact, if your PSA at some point should rise, or they're talking about additional treatment because margins come back not clean, then you would look at the high-risk recurrent group.
Oh, got it.
Targeted to dealing with more advanced situations.
Okay. Yeah, well, I don't know how fast the full pathology report's going to come. I think they said something like 6 weeks out, or that might be when they want to first check my PSA. But
they should have the report back in 2 or 3 days.
Okay. One of the I had Dr. Cooperberg was the surgeon from VA San Francisco, UCSF, and the 2 other urologists that were there as well. I talked to them, and they said that an initial and again, I was I was still in the hospital, so I think I was on medication and everything else. But they had mentioned that the margins came back negative, as well as the urethra. I guess it makes sense that they probably test that too, the section that they removed. The only thing that kind of threw me off was that my last MRI showed an extra capsular extension back in February. So they graded my tumor a T3A, and that coupled with my PSA that gotten as high as 41, it was 28 back in February. Based on those, I talked to my urologist in Reno and also one of the urologists at the VA San Francisco, and they agreed that a prostatectomy was based on my age and current issues hormonally and other things that I would that a prostatectomy was going to be the best course of action. However, after the surgery, urologist told me that there was no extracapsular extension. So I inquired about that, and they said that the radiologist and the approving physician on that MRI, they rated it as such, but it was probably something that they did more on a theoretical evidence than actually knowing my case and everything else.
Had they done a PET scan?
Yeah, they did a PET scan back in February as well, same day as the MRI.
And did that show ECE?
No, nothing at all. That was T2U and N0 M0. So it was all concentrated within the prostate. So the bad news is, I guess I maybe decided. The idea of the extracapsular extension did kind of become alarming for me, even though, the last 4 years of prostate cancer haven't really seemed to worry me too much. But I did start to feel a little more sense of urgency, with that being the result. And then now that having been a negative thing, I guess is both it was kind of threw me off, but also is probably good news in the long run. That the tumor had not extended outside of the prostate.
Certainly. There is, in terms of treatment, there's still no benefit for one treatment over another with the extracapsular extension, and checking with the PET scan to make sure that that's the case is helpful. And I think I would probably lean more towards agreeing with what the PET scan showed than the MRI. Anybody else have any comments for Cesar? Okay, thank you so much for joining us here, and look forward to seeing you back again. And hopefully they'll get you a good final path after they process all that.
Yeah.
And that you have a speedy recovery.
Thanks.
Billy Hayes, are you with us?
I am. Thank you.
Great. I'd like to go through our question list here, and then we'll throw it open to the group for discussion. Okay?
Okay.
How old are you?
I am 55 years old.
And where are you living?
Vancouver, Washington.
Okay, great. And I'm sorry, when I passed things along on the phone, was thinking Vancouver, Canada, which is certainly a different situation as far as management options. When were you first diagnosed, and what got them to make the diagnosis for you?
So I had my annual physical, and before it was over, when it was over, doctor said, hey, see you next year. Been my same doctor for 20 years. And I said, shouldn't I do some blood work? Because I had a cancer scare a few years ago with a tumor in my spine, and they got it out as benign. So that part's done. And he says, do you want lab work? I said, I think I should. So from there, I got the PSA score of 8 and went in for a biopsy 3 weeks ago, and then had my consultation 2 weeks ago where I was told I have prostate cancer.
Okay, now the biopsy,
it was all brand new to me.
You did not have an MRI before the biopsy, correct?
Correct. Yes. I just had a nuclear bone scan a week ago.
So the most important thing I can tell you is to stop. And in this day and age, for someone to do a prostate biopsy without an MRI, unless there's a contraindication, is just not a good standard of care. And doing a bone scan, it's clearly not the test to diagnose the extent of disease and if it's spread. In fact, do you have the Gleason score on your biopsies?
Yeah, Gleason score is 4+3.
And do you know how many cores were positive?
Out of 12, 3 of them were positive.
And do you know the percent of 4 in that 3?
Yes, it says Gleason pattern 4 represents approximately 90% of the tumor.
Okay. So that in itself is somewhat successful or significant, but I think it's important that you have, and I want to throw this open to the group, looking at those spots, cores, and having a second opinion on the cores, or looking at a further a repeat biopsy if they're targets on the MRI. I don't know that we know the extent of your disease without an MRI and without a PET scan. If it's truly 4+3, a PET scan will help to say that the disease appears to be limited to the prostate gland. It does not say that for sure, but there can still be microscopic disease. But Gleason 4+3 needs evaluation, and probably by someone who can do a better job than the person you're seeing right now. What have you been told are your options? What are they suggesting?
So immediately, my wife and I went to the consultation. Surgery was brought up, and then radiation after the surgery. But we didn't feel real comfortable with the information we got, so we have a second opinion coming from we're heading to the University of Washington, Dr. Shade, the first week of June. But that's the only options we're given is surgery and then radiation. And you didn't want to do radiation first because the scar tissue will prevent the surgery, is what we're told.
So in this day and age, that used to be a myth that they would suggest that you do surgery first because then you can do radiation. But even if you have a recurrence after radiation, it could be at the edge at which can be radiated. It could be another area if it comes back. But the ability to focus the beam of radiation in the last 5-10 years has improved so much that if you have a recurrence that's within the prostate, you can retreat it and you don't have to turn to surgery. And the other thing that you will hear is that at age 55, you're young, and young people do better with surgery. And what they don't tell you is the second half of the sentence, which is young people do better than older people when it comes to surgery. But it also, they don't tell you that for the next 30 to 40 years, you could be leaking urine. And at 55, you could develop impotence that could hang with you. Now, in a lot of people, that can be worked on and can be corrected, but not always. And it can be an ongoing problem for you that with radiation doesn't seem to be the case. I don't know if you were here for the earlier talk, but we had the people from Miradex, and they do genetic screening to predict risk of response with either a fast rate radiation, which would be 5 days, or slower radiation, which would be 20 to 28 days of therapy. I don't know who the best people at Hutch are in the Seattle area. I know that there is one clinic that is using the MRI linear accelerator, which is a state-of-the-art treatment in the Seattle area. I think it's in Bremerton, but I'm not sure. So let me throw it out to the whole group here, and then we'll come back to you and see what further questions you have, Billy. But I'm wondering how to deal with the fact that it was a random biopsy and it was just 4+3.
Yeah. It's interesting. This is the second time this has happened in successive weeks or 2 weeks apart. Billy, I think the most important thing to take away is that you've got to get yourself out of your local urologist or urologic oncologist in Vancouver, Washington, because any urologist today who is doing a biopsy, and it's not a fusion biopsy, meaning they haven't done an MRI first, they're not up to date with how to practice. I mean, it's just not done anymore. And going to Hutch is a really good move. I've been looking through the urologists at Hutch. This isn't really my area. I know the GU Medoncs at Hutch pretty well. I don't know if Sharda's the best. I think that you should be doing some, don't just take the first guy they give you. You should be doing some checking around as best as you can. But, Sharda may be right. I just don't know. But I think you've got to literally start all over again at Hutch. Now, one thing that you can do based on what you have right now is what we call a nomogram. And we recommend the Memorial Sloan Kettering nomogram, which will give you a pretty good idea as to how likely it is that surgery alone will meet your needs, and you won't need radiation, because there's no guarantee that you need radiation. It's really based on how serious the surgery is. In my own case, I was diagnosed age 56, just a year older than you. The likelihood, and I wanted to do surgery, but the likelihood was I only had a 30% chance of success and would need radiation anyway. So if it turns out that you're going to need radiation anyway, then maybe you don't want to do the surgery. It's a smarter decision to go straight to radiation and hormone therapy. And that's one of the things that you should be thinking about. What is the benefit of surgery for you? There is a benefit, but it could be very, very small and not worth putting yourself through a whole bunch of additional side effects. And that's what I think that you will get out of Hutch. You should also be seeing a radiation oncologist there, as well as the urologic oncologist. And between them and with our help, we can help you make the right decision.
Thank you, Rick.
I want to make a really quick comment for you guys, which is that Billy has been operated on at UCLA, and he has family lives about 30 minutes from.
Hutch is as good as UCLA, I mean that Hutch is a very, very good. It's an NCCN cancer center. I mean, we could send you down to the urologic oncologist there, but I think you're going to get just as good treatment as at UW.
Not trying to say differently, Rick. I just wanted to cue you into that info.
Right. I mean, if you were living in the middle of nowhere and you had to travel, it's different. But I think that if you're comfortable going to Hutch and you're set up going to Hutch, I just want to be sure that you get the best doc there. And frankly, I don't know. I don't know who the best urologist is. We used to work with, I mean, the Westphalen, the guy that we really like, the radiation oncologist that we really like, if you can get an appointment with him, and he knows us really well, is Antonio Westphalen, Westphalen. And he would be sort of a good guy to start with as well. And he knows AnCan. So yeah, but I don't have a urologist, urologic oncologist that I can throw at you right now.
Okay.
Rick, John was mentioning that Vancouver, Washington is next to Portland, Oregon. Do we know anybody in Portland?
OHSU is a mess right now, and frankly, it is. But I mean, you know, if you'd rather go down to UCLA than go up to Seattle, we can certainly give you some names down there. OHSU, they're not in great shape. There's too many things have happened, and I'm not sure I would go to OHSU right now.
Perhaps the big point would be that he should be looking for some MRI guided information, so to speak, starting over like you guys were commenting.
Yeah, you're right, Nick. I mean, that to me, I think Dr. Mark and I would both agree, and Dr. John dropped off now, but I think he would say the same thing. I mean, we really don't have a good enough feel on your disease for you to be making any decisions.
The only thing is, would you buy the 4.4+3 enough to get a PET scan if it showed that disease was limited to the gland? You still want to know 4+3 versus a higher grade might mean longer ADT. So you really have to know what the disease is. And, you know, I think as we spoke before, we really don't know what's going on.
What about the Seattle Hutch group in terms of second opinion on pathology, or should we be telling Billy to try to go to Johns Hopkins or Mount Sinai?
Well, I mean, definitely, I would say you should be going to Zhao or Epstein, and then probably third choice would be Hopkins. But you see, again, the problem is we don't know whether we've gotten the right targets in there. This is the biggest concern. We just don't know if we've gotten all the right targets because it was done blind.
Maybe Hutch can help Billy out with that information, meaning, so to speak, the starting over like you guys were commenting on.
Unfortunately, I really think that when you have disease with 90% 4 in cores and it's 4+3, you really want to make the right diagnosis because it can really make a difference.
Well, yeah, you know, I mean, let's just say it was what's your PSA again, Billy?
8.
Yeah, you know, it's and what was your PSA a year ago?
This was the first PSA score I've received.
Oh, this was the first PSA, so they never monitored it. I mean, 8 is not particularly that high with that sort of disease, which is a little bit of a concern to me. But, you know, I don't even want to be taking conclusions on 90% of the core being 4 because we don't know what else is there. I mean, if you were, God forbid, you were a 4+5 or a 5+4, it's going to change your treatment. It's going to change your treatment decisions. So you can't be making any treatment decisions, frankly, until at least, you know, we've done the MRI and we've got a good sense as to whether, you know, they can look at the MRI, they can look at the ultrasound, and they can see if there's areas that they still need to be testing. But I think you need some really good guidance from Westphalen might be a good starting point. He's a great doc, and he cares, and he gets it. And if he thinks that you should be going for surgery first, he's going to tell you. He's not going to tell you that you have to do radiation, but he gets the ins and the outs.
Billy, correct me on this. You don't have like a bunch of your cores. Some of them were benign, and they were 3. Some were 3+3s. They weren't all. He's just talking about it was 90% of one of the cores or 2 of the cores. Correct, Billy?
Correct. There was one, yes, and there's another 4+3. That's 80%, and that was in the right apex, and then the right mid was the 90%.
But there were also some that were benign, correct?
Correct. Yep. Number 1 was yes.
Okay, so it sort of boils back to what you guys were saying, that he needs to get a good idea of where he really stands.
I think that's our thought. Eric, you've got your hand up.
Yes. Hey, Billy, quick question for you. You said you had 90% of one of the cores. Is that definitely pattern 4 or just 90% of cancer?
It says Gleason pattern 4 represents approximately 90% of the tumor. And then it says the exact same thing for 80% of the tumor, and the one above it.
Okay. I'm trying to decipher if it's really a pattern 4 percentage or just an overall cancer percentage. You know, is it just of the 3+4, is it 90% of the core has cancer and we don't know what pattern 4 there actually was? And that's where a second opinion might help.
Yeah, it's definitely where I'm going towards now.
You're saying a second opinion on the biopsy, Eric?
Yeah.
Yeah, but it's too soon because we don't know. We don't know what's there. We're not getting a definitive second opinion because we don't even know if we've got all the right stuff yet.
I think I'd buy a PET scan and an MRI and then decide.
I mean, yes, you'll need a second opinion on the biopsy. Absolutely, you will. But the question is when. I tell you what I think I would do, Billy. I'd call up Hutch tomorrow and see how quickly you can get an appointment with Westphalen, okay? And tell him you're an AnCan person and that AnCan is really, really dismayed about how your local urologist has been treating you, and they feel you need to start over in a hurry, and that you really need somebody to navigate you. And AnCan is suggesting Dr. Westphalen, not necessarily because you need radiation, but because we know that he'll do a good job navigating you. And see if you can get in to see him on that basis. And I'm sure he'll see you on that basis. There was a time when he used to do all our second opinions on rereading scans and goodness knows what. And he's done webinars for us, and he's just a good guy. And I kind of feel that if you were in his hands, you'd get reset. You'd get a reset in the best possible way.
Okay, and Phalen, is that F-A-L-E-N?
It's in the chat window. The chat window, you see those 2 little squares next to where it says 20 at the top of your screen?
Oh, yeah.
Okay, open that up and click on that link, and it'll open up in your browser, and you can look at it later.
Got it, Antonio. Oh, got it. Perfect. Thank you.
Billy, any other questions for the group tonight? If not, we're going to move on. But anything else?
No, I appreciate the information I got. This is all brand new to me, and I'm getting ready for high school playoffs in baseball and trying to manage this at the same time.
Yeah, and please let us know. please let us know what you decide and what you find out, and keep us
Yeah.
updated.
Mark, would you mind putting
Absolutely.
your email in the chat window for Billy? And Billy, if you get any pushback with Westphalen, let us know. We'll drop him a line.
I really appreciate it, guys. Thank you so much.
So Billy, Mark's the same Mark that we connected you by email last week or the week before, okay?
Oh, same one. Okay, thank you.
Great. Richard, you are up. Thank you for your patience and hanging out.
Okay. Yeah, thanks. Yeah, I just want to update everybody and then have a general question to the group. It's been 1 year since my treatment, SBRT, last May. And needless to say, when I had my first PSA reading after that, which was in October, it was 5.95. So I was really, really anxious. I thought it was going to be much lower. But now time has passed, and I had another one in January. It was 3.87. And then just last week, I had another PSA, so it's 2.48. So just to summarize it, after a year, it's on a downward slope. I had thought it was going to be below 1.0, so I've had to live with these numbers. But my general question to the group, anyone out there, 1 year after SBRT, have they experienced any lingering side effects? I mean, the frequency of urination at night is still really high. I have some urge incontinence, so I just wanted to see when I'm on medication, alfusosin and teleterdine, I believe is it, and that's reduced the discomfort of urinating. But I just want to just kind of survey the group, those who are 1 year post treatment, what sort of side effects have people experienced?
Well, one thing that's interesting, Richard, you might contact the people who were here earlier from PROSTOX and see if,
missed it.
yeah, because they said that they are looking for some people. They're still gathering cases, and you could tell them your symptoms and see if it's still worth getting the test. And they might want to do that to see. They're saying about 7 or 8% will have a genetic pattern that puts them at greater risk for symptoms after the first 90 days. So there's one group that has early on, almost immediate symptoms, and then there's development of late symptoms. And usually it's pretty low. It tends to be more GU than GI with it. Also depends on the type of SBRT, how it was delivered, whether it was an MRI Linac or a CT or CyberKnife. All those have a little bit different profiles. If they say that you have a radiation cystitis, you may ask the radiation oncologist if you might benefit from hyperbaric oxygen. If the symptoms are annoying enough, 15 to 20 treatments may reduce and be effective in up to 90% of people. Now, you'd have to be in a tank for an hour and a half to two for all those sessions. But that seems to be very effective for dealing with radiation cystitis. Have they talked to you about potentially doing a cystoscopy to look at the bladder or prostate?
Well, I'll have that appointment on Wednesday. I'm sure that'll be a topic for discussion.
I had a brief episode where it was almost like a bladder infection, where I was getting up throughout the night and many times during the day, and every 45 minutes to an hour going to the bathroom, and got a cystoscopy, and there was inflammation and blood over the prostate. And after another week or so, that cleared up. Still got a little bit, but not really any different than before entering into the whole process. Anybody else have some experience with bladder to share?
Yeah, I mean, Richard, the the likelihood of radiation cystitis and radiation proctitis continues for several years after the surgery. I mean, in my case, I didn't have any bleeding for about 2 to 3 years. And eventually, when I did, it was repetitive. It wasn't that bad. And in the end, they checked it out with a cystoscopy, and it was a nothing. There wasn't anything there. My bigger issue was the proctitis. But radiation keeps on giving. You know,
I know.
it's not going to all be done that quickly. At the same time, for many people, the way that the cystitis and the proctitis manifests is not that serious. It's not bothersome.
Okay.
So if it's not, I mean, if you still are having the urgency, okay, that's a significant issue, and that may be a result. But if you're not having urgency, or if it's just the bleeding, it's to me, for me, it was less of a concern, and it turned out there was really no concern. But it happens to a lot of guys.
Okay. Yeah, I certainly have no bleeding. It's just the issue of urgency and then occasional urge incontinence.
Yeah, I mean, I think that's a discussion with the urologist.
Okay.
One thing I don't know if you get to experience and enjoy the Beltway right outside of Silver Spring, but you might invest in one of these emergency car kits in case traffic is so bad that you can't make it out. I only had one episode of incontinence due to urgency, and it was rather embarrassing because I was going to a political rally, a presidential rally. I was not set. I hadn't donated enough to see the president, and I was hoping that the president could not see far enough to see. Luckily, I was wearing black pants. But security took way, way too long, and I didn't figure the half an hour in the security line at that point. I think I can do it now, but be prepared and have backup.
Okay. All right. Thanks.
Anybody else have any comments? Jay, you got here late, and I wonder if you needed any time this evening.
Oh yeah, hi, thank you. Sorry about that. Yeah, I'm just waiting to see my doctor to follow up because I got the report back from Johns Hopkins, and they're apparently saying there's basically not enough indicators to say it is cancer. So, and I did speak with my urologist that I normally see, Gary Bellman, who had done the biopsy. And all he could say was, gee, it's a real head scratcher. And I'm like, okay, that's a real professional comment.
Yeah. Did they do
anyway,
an MRI? Was it an MRI before the biopsy?
Yes, it was guided. It was targeted. And they had done one 6 years ago. They had seen lesions, but it was pin the tail on a donkey, and it was benign. I asked him, can you tell if these were the same lesions or not? And he said no. And I'm like, well, you've got both MRIs. I would think you'd be able to look at them, but I don't know if that's possible.
It sounds like yes. I mean, and it sounds not at all unusual. If you wanted to get a second opinion on the path, you could. But usually if there's, you could get the second opinion, and they're saying they're not cancer.
Correct.
No, I think I'd be happy.
Yeah.
And ask how they want to follow you. That's the thing that's.
So I guess just the one other thing that's on my mind is, when I see the urologist that I'm seeing at UCLA, who I trust more, He's a urologic oncologist. I asked him when I saw him previously about doing like a PET scan or whatever, and he says, no, that's not necessary at this time. I don't know whether I should ask for that if there is cancer, if it's spread. Of
Yeah,
course,
they're not going to.
everything's inconclusive at this point. So,
So it will not have spread if it's not there.
Mhm.
And the scans are expensive, and they're also false positives. So without evidence of a positive biopsy, if you
I see.
did a PET scan
Mhm.
and it came back positive, then you'd be chasing something that more likely than not was
Mhm.
not a cancer.
I see. Yeah.
So I think at this point, I think you say, well, I'm one of the lucky guys.
Yeah.
And, maybe more inactive surveillance is the type of thing if they want
Yeah.
to follow along.
So, I don't know if I'll be able to still attend these meetings or not because of where I'm at now. I will wait to see the doctor and see where we're at, and go from there, and just probably continue active surveillance. He did send it out for DECIPHER. We're waiting on that, and the PROMISE test said non-genetic, so I
It's
did that one
interesting
too.
that they would do promise without confirming a cancer on the diagnosis.
Oh well, I just sent it out on my own because you guys recommended it.
Okay.
Yeah,
Um,
but the DECIPHER, I requested it with Dr. Seigel at UCLA, and he said, sure, we'll send it out. So he did that.
okay.
So I think you definitely need to attend one of our meetings, Jay, whether it's the active surveillance or this one or both of them.
Mm,
Um, yeah, you need that support,
I appreciate
especially
that.
with the uncertainty that you're
Yeah,
going through.
yeah. I think
And,
what I'll do is attend the active surveillance and listen in on this one and give you updates if there's anything new.
yeah, I mean that's yeah, you're very welcome to join both of them, but let us keep helping you try and unravel what's going on here. And as Mark says, there's absolutely no reason for you at the stage that you're at to be doing any of these PET scans or anything like that.
Okay. Yeah, because right away Dr. Bellman was like, go see a radiologist. And I was like, whoa, hold on a minute.
Well,
Yeah, I think
that was a while back, and that's why you come to
Yeah.
groups like ours and we get you
Yes.
straightened out, because you're a sort of guy who could have finished up getting treated when you never needed it.
Right.
I
Well,
mean,
I was in a cautious mode though. I remember I told you guys I was going to go see the radiologist, and you said no, don't go. And I says, well, I'm going just to learn. I wasn't taking any action, and the guy was like a salesman. I didn't like that.
that's so sad when, particularly when it comes back like this, and when
Yeah.
you have the discrepancies or differences
Yeah.
between the different labs.
Thank you all.
But you are welcome, and thank you for stopping by. Michael in Denver, Michael Wynn, how are you doing? And do you need any time this evening?
No, I'm fine. Thanks. Thanks a lot, Mark. Appreciate it.
Okay. Anybody else? We are done early. We're solving the world's problems in record time here. So we appreciate everybody checking in. Anything else? Okay, so it's still early on actually no, it may be late, or it's just starting now. My son-in-law is singing on The Voice tonight. He's in the choir, a group of, I think it's 6 people. He sings on 2 songs. So if you're a Voice fan on NBC, turn it on and say, someone who knows that. I ended up babysitting earlier today, so he could run off. He called me at about 9 o'clock. Oh my God, someone has to pick up Hugo. How are we going to do this? So, they knew yesterday, but they didn't think to ask until today. So
Okay.
everybody had a wonderful time.
I just want to say that for people like Richard and anybody else who may have missed Dr. Whitehouse talking about the Protox test, It was excellent. It was about 50 minutes long, and it was recorded, and it will get posted, and we will feature it in the reminder. So you'll be able to catch it later on. But I think it was very. You can leave, by the way, Dr. Mark. I'll close the meeting. You can leave. I want to ask Stuart, because he was diligently paying attention. What did you learn? Anything about from the PROSTOX presentation, Mr. Jordan?
Well, it was interesting the way that she described that they approached it in terms of the fact that they're not considering every case is the same. They're basically looking at it from the perspective of every person is different. So, I got more perspective on it today than I did when I did the test, where it was really sort of just swab, get the piece of paper, move on.
And Zol, we'll come to you in a second, but Eric, are you more straightened out on what this test does now? Do you have a better feel for it, or do you have any questions?
I mean, I need to watch it again, because I guess I got lost in like, what is it really for? Is it just for SBRT, or is it for all radiation treatments? Or I just need to watch it again.
There are two panels, and they have one panel that if you have mutations in that panel, SBRT would be a greater risk. They have another panel for lower rate, and you can have a patient who can do SBRT, but is at greater risk of side effects from doing slow delivery and IMRT. So this thing where you go to the radiation oncologist and they say that, well, we don't know about SBRT, there are more side effects, so we're going to do it slowly. That tends to be a myth. It's that each one of us, some will do better with a fast delivery rate, some will do better with a slow delivery rate. The tumors are more responsive to the higher rate than spreading out over 28 or 45 days. So that's something that is interesting.
That's called fractionation?
Yes. Ultrafractionation is 5, hypofractionation is 20 to 28.
Right. Zol, you have your hand up.
Yes, sir. Thank you very much, everybody. I'm glad I found you guys. I was not ready today. I didn't have all my ducks in a row here to go into much detail or have a productive discussion, but I will be back. I'm just wondering if in 2 weeks, because of the holiday, will there be a meeting?
Yes. We're like the post office, the USPS. We never close.
The Pony Express.
So, and are you signed up to get our reminders, Zol?
I am not.
Okay, well, if you you can sign up in 2 ways. You can go to ancan.org, ANCAN.org, and you can sign yourself up, or you can put your email in the chat window, either to Mark personally, me personally, or to everybody if you're willing, and we'll sign you up.
Okay, great. Thank you. I am from the Ann Arbor, Michigan area, and currently working with the U of M people for a second opinion. So.
Okay, well, they're a good group there. They're a very good group. So.
Okay, great. Excited to hear more about your guys' and all your knowledge and wisdom. So thank you very much.
It's a pleasure.
Thank you.
We'll see everybody in 2 weeks. If you don't make it, have a happy Memorial Day weekend.
Oh yeah, hold on, Eric. I'll answer your question. I'll answer your question.
Want me to stay on?
Yeah, stay on for a second, and then I can respond to you. Otherwise, you'll go, and then I'll have to